Hi everyone, I'm Perlita Cabrera and this is my comprehensive care project. So, my patient was a 29-year-old Hispanic male who was single and a fiber laser operator. His chief complaint was, I need a deep cleaning since I haven't had one since 2 to 3 years ago, so I know I am very overdue. His medical history indicated that his last physical exam was in March 2021. No systemic conditions, no family history, no medications, but BMI was 35.2, which makes him into the obese category. His first appointment vitals were within normal limits except for the blood pressure. Blood pressure was 130 over 78, which is stage 1 hypertension. Due to the hypertension, the BMI, and being a social drinker, I categorize him as an ASA2. For dental history, his last dental exam and deep cleaning were 2 to 3 years ago. He had orthodontic treatment approximately 12 years ago in high school. He had an amalgam filling of number 30 occlusal. He had an extraction of the third molars approximately 12 years ago. For his assessment, extraoral and intraoral, the TMJ had slight deviation to the right upon closing. It was asymptomatic. There was no pain. He has an overjet of 7 millimeters. Angles classification showed that left and right canines had no contact, so there is an open bite of the anterior teeth. And left and right molar were a class 1. There was exostosis on the maxilla and mandible, and everything else was within normal limits. The maxillary attached gingiva was pink, red, and stippled. Maxillary free gingiva was pink, rolled borders, and blunted papilla. Mandibular attached gingiva was pink and shiny. Mandibular free gingiva had blunted papilla, rolled borders, and cleft on number 25. Here's an image that shows a 7 millimeter overjet, and here is the open bite on the anterior teeth. And here's an image that shows the maxillary molars. They have decalcification on there. For periodontal charting, anterior teeth were generally 3, 2, and 3s. Probing depths were 4s and 5s on the molars. In the radiographic findings, there was severe resorption of the maxillary anterior teeth. Crown to root ratio was 1 to 1, and it could be due to past orthodontic treatment. There was bone loss, mostly horizontal, on the posterior molars. There was widening of the PDL on the mandibular molars and premolars. Disease appears active interproximally of the mandibular molars and between number 6 and number 5. There's thickening of the lamina dura on the mesial root of number 19 and amalgam restoration on number 30 occlusal. And when looking at the radiographs, there may have been clinician errors on periodontal probing, possible discrepancies of 1 to 2 millimeters on the posterior teeth. The baseline plaque index was 56%, bleeding on probing was at 12%. My patient presented with inflammation in the full mouth. There was deeper probing depths of 4s and 5s on molars, mostly horizontal bone loss on the molars. So I categorized them as generalized gingivitis, plaque-induced, and localized periodontitis to the posterior teeth, stage 1, grade B, and Wesley calculus code was a 3 light medium, and the grading was due to destruction commensurating with biofilm deposits, and the calculus code was due to 50% of the calculus being present in interproximal and subgingivally. After assessing my patient with a camera, it shows he was a social drinker. He has visible plaque and deep pits and fissures of number 18 and 19. So this indicated that he is at moderate overall caries risk. After evaluating my patient's 3-day nutritional journal, it showed that he had a high calorie diet on weekends, high carbohydrate intake in general, high acid exposure times. And so the recommendations were to reduce coffee intake or exposure time, drink more water, eat more nutrient dense foods such as vegetables and fruits, nuts, eggs, Greek yogurt, and lean proteins. My patient is susceptible to caries and would benefit from making modifications to his diet, and this may also aid in a healthier BMI with time. For a treatment plan, we will go over the appointment sequence, referrals, and oral hygiene instructions. For my patient's treatment sequence, I plan to do the lower right quad SRPs with anesthesia and OHI. All of these SRPs, my patient declined anesthesia. So we ended up doing lower right quadrant SRP OHI, and then upper right and with the OHI, and then lower left quad and upper left quad SRP. Um, and we also did sealants on number 18 and 19 and OHI. On the fourth appointment, we did the reevaluation, and I recommended a 3-month recall for perio maintenance. For the referrals, I referred him to the general dentist for a TMJ evaluation due to slight deviation upon opening. There are radiographic signs of excessive occlusal forces on the molars. There's widening PDL, thickening of lamina dura, and there's clinical signs for the need of a night guard, which are the bilateral exostosis on the mandible and the maxilla. I did refer my patient to the orthodontist to address the open bite, and hopefully they can treat that, being mindful of the root resorption. I did refer him to the physician to address the stage 1 hypertension, just to make sure that everything is okay, and the nutritionist, just to obtain a healthy range of BMI, and it would be helpful to have guidance on nutrition and in the long run be able to obtain a lower BMI. For OHI, we reviewed toothbrushing and flossing. For his pre-treatment technique was back and forth scrubbing. It was fast scrubbing motion and missing areas. So we went over modified bath technique. I did tell show do on the model, and then the patient tried it on himself. For flossing pre-treatment, he did not floss regularly, and he would use floss pick when it was needed. And his technique was the seesawing motion. It was not going up and down. So we demoed the C-shaped flossing technique. We did tell, show, do on a model, and then we had patient try on himself. So during OHI, I made sure to provide information printed. That way he can take it home. We went over how cavities are formed and what is periodontal disease and how to control and prevent any tooth decay. And then some OHI recommendations. I recommended Act Anti-Cavity Fluoride Mouth Rinse to add some protection of the enamel. I recommended a power toothbrush to use dental floss at least once a day, brush twice a day for at least 2 minutes, and remember to switch out a toothbrush every 3 months or when there's signs of wear, and to drink more water, especially after meals, to disrupt the biofilm and reduce food debris. For the reevaluation, um, the outcome, I'm sorry, the outcome of the treatment was the plaque index was reduced from 56% to 26.6%. Bleeding and probing was reduced from 12% to 5.3. Marginal bleeding index reduced from 5.5 to 2.6. And Wesley calculus code was a 1 light. So here you can see the image of the first appointment and then the reevaluation. On the date of the reevaluation, there is less redness along the marginal borders here. There are still rolled borders, but it's not as inflamed. And I think that we made some good progress. For the plaque index, here is the baseline in comparison to the reevaluation, as well as the bleeding on probing. Periodontal chart reevaluation. Probing depths were generally 3 to 3 millimeters and localized 4 to 5 probing depths on the molars, but there weren't many. I can't say there was a lot of improvements or much improvement due to what I believe was clinician errors on the baseline probing, but generally it remained the same with the higher probing depths on the molars and less on the anterior teeth. So, for the reevaluation, patient compliance, the patient is compliant with oral hygiene suggestions to the best of his ability. He stated he was brushing every night and every morning for 2 minutes. He was also flossing a couple times a week. At night, he was using floss picks with the goal to increase how often he's flossing. And sometimes he uses Listerine mouthwash. For the preventative instructions, being moderate risk for caries, my patient was not compliant to incorporate an anti-cavity mouthwash due to not wanting to purchase an oral rinse when he still has them at home. He plans to make the switch once he finishes his current oral rinse supply. Nutrition wise, my patient was compliant with water intake. He did increase that, especially after drinking coffee or foods that were acidic. He is also in the process of getting a gym membership to start exercising. He is making nutritional changes such as eating cleaner meals and less unhealthy meals on the weekends. For the referral recommendation, my patient was not compliant with the referral to the DDS or orthodontist. He stated that he does not have a dentist at the moment, but will work on finding a dentist he is comfortable with as he gets busy and needs to find the time. He was compliant to the referral of going to the physician to address his blood pressure. He stated that he did become concerned about the elevated blood pressure and had a checkup with his doctor. His examination came back within normal, and he is going to start exercising and continue to drink more water and modify his meals. So, according to Association Between Obesity and Periodontal Disease, systematic review of the epidemiological studies and controlled clinical trials, obesity is characterized by a chronic subclinical inflammation that could exacerbate other clinical inflammatory disorders such as periodontitis. And this means that this is putting my patient at a higher risk to develop periodontitis, or in this patient's case, the slight localized periodontitis can progress on the posterior teeth and put a greater risk of disease on the teeth with significant root resorption. This makes it imperative to educate the patient about his oral condition and encourage him to continue regular dental examinations and hygiene services. And also, according to research found in the Open Dentistry Journal, malocclusion like the open bite that he has can lead to temporomandibular joint disorders. Anterior open bite may add most, if not all, forces to the posterior teeth. This may cause bruxism, which will cause more wear of the occlusal surfaces of the contacting teeth, as well as overdevelopment of the masseter muscle. These full load forces may lead to headaches, muscle pain, jaw joint pain, clicking, popping, a lot of TMJ symptoms. So, I'm sorry, TMD symptoms, and toothaches and risk of tooth fractures. If this patient's symptoms progress, there could be a continuous widening of the PDL, which can eventually lead to mobility of those teeth due to the excessive occlusal forces. And so, in conclusion, although there are high risks for periodontal disease due to the high blood pressure in obese patients, this patient's current condition is considered slight periodontitis and has demonstrated motivation to obtain a healthier and stable periodontium. He presented with compliant feedback such as increased brushing time and started flossing more during the week and increased water. He increased his water intake, help acidic to reduce the acidic exposure time after sugar intake, and is determined to become more active by searching for a gym and will be seeking a dentist and orthodontist. He also did make sure to have a physical exam, and though he was not diagnosed with hypertension by his physician, we will continue to monitor this at every appointment to ensure proper care and counseling. As long as he continues to be motivated and applies recommendations at home and nutritional modifications and increases in activity levels, I believe that there will be a good prognosis for his overall periodontal health. The modifications may lead to arrest any active periodontal disease and reduce the likelihood of further progression of the periodontitis. Here are my references, and thank you so much.